Good day, everyone. Welcome back again. In this video, we'll continue our discussion on respiratory geriatric clinical care. In the previous session, we described age-related anatomical and physiological changes in the respiratory system, explained how aging reduces respiratory reserve and compensatory capacity. By the end of this session, the learner will be able to 1. Recognize atypical respiratory presentations in older adults and identify early indicators of respiratory decompensation. 2. Explain the concept and clinical significance of silent hypoxia and identify aspiration risk due to airway protection failure. 3. Integrate functional, cognitive, medication, and comorbidity factors into respiratory assessment. Now, we will continue to explore how respiratory illnesses present atypically. Older adults often do not present with classic respiratory symptoms. Respiratory illness may present as confusion or delirium, reduced appetite, falls or near falls, generalized weakness, and sudden functional decline. Early indicators of respiratory decompensation include increasing respiratory rate even within normal range, oxygen saturation trends, shallow breathing, reduced activity tolerance, new confusion. It is important to know that waiting for cyanosis or severe distress is unsafe. Next, let's consider what silent hypoxia and aspiration risk are. Silent hypoxia refers to dangerously low oxygen levels without obvious respiratory distress. Contributing factors of silent hypoxia include reduced sensitivity of respiratory centers, altered perception of dyspnea, sedating medications, chronic respiratory adaptation. Do you know that patients may appear comfortable while deteriorating rapidly? Now that we understand the contributing factors of silent hypoxia, let's move on to discuss aspiration risk and airway protection failure. Aging impairs airway protection through delayed swallowing reflex, poor coordination of swallow and breathing, weakened cough, poor dentition, neurological impairment. Aspiration may be silent and recurrent, making it a major contributor to pneumonia and decline. In older adults, pneumonia often presents atypically with absence of fever, minimal cough, normal white blood cell count, prominent confusion or functional decline. Delayed recognition significantly worsens outcomes. Let's proceed to how we can prevent respiratory decompensation. Preventing respiratory deterioration in older adults requires careful attention to risk factors that may not be immediately obvious. Preventing respiratory decompensation can be done with the impact of medications and comorbidities. Certain medications increase respiratory risk, including opioids, benzodiazepines, antipsychotics, muscle relaxants. The comorbidities include stroke, dementia, Parkinson's disease, and heart failure further impair respiratory safety. Let's see functional decline as an early respiratory signal. Functional decline often precedes measurable respiratory abnormalities. Early indicators include reduced walking distance, increased fatigue, new dependence in daily activities, reduced alertness or engagement. These changes should prompt respiratory assessment. Finally, let's talk about the geriatric respiratory clinical reasoning framework. Advanced practitioners should ask, what has changed from baseline? Is the respiratory reserve limited? Could this be silent hypoxia or aspiration? What is the risk if this worsens overnight? In conclusion, early recognition through changes in function, vital signs, medications, and comorbidities, guided by geriatric clinical reasoning, is essential to prevent delayed intervention and serious outcomes. That's it for now. Thanks for watching. See you in the next session.